This conference will now be recorded.
Hi, everybody. This is John Antonucci. This is AnCan's high-risk metastatic advanced prostate cancer support group for Tuesday, August 12th. I have with me several other moderators who are going to support me and you, Ben and Len and Jim and Bill, if he's still here. Yeah, he's still here. Did I miss any of the team? We are going to be talking for the next couple of hours about prostate cancer, share our experience. We're not going to give any medical advice. We urge you to talk to your medical team about anything that you hear and want to consider. We'd like to acknowledge support from several organizations that are help keep us on the air, and that's Bayer, Johnson & Johnson, Myriad Genetics, Telix, Blue Earth Diagnostics, Foundation Medicine, and Novartis. Now, I've got a couple of new guys here. I'm going to just ask you some questions about your history so that we can all get to know not only about you, but what you want to hear from us. My first new guy is Sam. Sam was referred by Jim Marshall. Probably because of that, he's a veteran. And how old are you, Sam? You have to hit that microphone button in order to unmute yourself.
Yeah, I'm 81, a former Navy corpsman, and came through to your group through Russ Seneca, who referred me to
Russ, not through
Yep.
Jim. Okay. Very good.
I
Tell me, please, when you, where do you live?
I live in Naples, Florida, but I'm currently on vacation in Las Vegas with an outside temperature of 110 degrees.
That might win you the prize.
I have the list of information that you requested, and I've been a PA for a number of years, so I can run through it real quick to give everybody an overview if you like.
You know how to present the case quickly, don't you?
I do.
Sure.
Okay.
Shoot.
So I wound up with a PSA of 4.7 in November of 2011, confirmed it in January, did 45 doses of rapid arc radiation. That dropped my PSA down to 0.8 and went along pretty good from 2012 until April of 2020 when I had
let me intervene here just for a minute. Before
Sure.
they did that radiation treatment, did they give you a biopsy?
Yeah, of course. I had 14 biopsies, 3 positive with a Gleason 6/7.
Gleason what?
A Gleason 6 or 7, which was
6. I think one was 2 or 6 and one was 7.
And the 7 was a 3 plus 4, a 4 plus 3?
3 plus 4.
Thank you very much. No unusual pathological features other than just regular adenocarcinoma. Nothing fancy. Okay, please proceed.
Okay, so I also had a confirmatory biopsy of the prostate in March of 19 that was negative. My PSA started to go up. So I had an Axiom PET scan back in April of 20, that discovered a 1 centimeter lung nodule. We watched it for about 6 months. And as my PSA started to rise, I wound up going to UPenn, and the lung nodule had gone from 1.0 to 1.2. Long story short, in July of 21, I had removal of my right middle lobe with metastatic prostate cancer um, there. My PSA, go ahead.
Oh, that's okay. Okay. I'm caught up. Go ahead.
Yeah, and it was a neuroendocrine hyperplasia of the nodule.
Oh, it was,
Yeah.
but it wasn't lung cancer. It wasn't
No,
small
not at
cell
all.
lung
No.
cancer. Okay.
It was at that time surprising to my oncologist, my urologist, that it was metastatic prostate cancer to the lung.
Yeah. Yeah. So, and then you have no lymph nodes, bone mets, visceral
Now,
mets other than lung or anything. Okay.
hold on.
Okay. Go ahead.
PSA,
Who was your UPenn oncologist?
um, bear with me a second. At the time, it was Dr. Narayan, Narayan.
Yeah, we know him very well. He's a good doctor.
And right now I'm being watched from day one. My urologist in Naples is Rolando Rivera, and my urologic oncologist in the Cleveland Clinic in Fort Lauderdale is Dr. Arteta Bulos.
Do you know,
So
do you know that person, Rick?
I don't. Who's your Naples doctor again?
Rolando Rivera.
Orlando Rivera,
And that's a urologist, right?
no,
Urologist.
that's the medical oncologist, correct?
No, Rolando Rivera is the urologist, and Dr. Arteta Bulos, that's his last name, Arteta, Arteta dash Bulos, Bulos, is my medical oncologist.
And where is he?
Cleveland Clinic, Fort Lauderdale, Florida.
Okay, thank you.
Mhm. So,
Dr. Artelaboulos, a GU specialist?
yes, yes.
Thank you. Yep. Okay.
So, my PSA initially went from 7.2 after the removal of the right middle lobe. It dropped to 2.6, and then it started to climb up again. And that's when I had my first PSMA, and they discovered a 1 centimeter nodule in the left anterior hilar region and a 4 millimeter nodule in the left lower lobe. And that was a CAT scan, and eventually the
That was a
PS.
CAT scan and a PET scan, right?
That's correct, yeah.
Thank you.
And so my PSA continued to rise from 3.7 in May of 22 to about 7.8 in October 23, and that's when I went on, and that's when I had another PSMA, and it discovered uptake in the within the small bilateral hilar lymph nodes, mild
Okay.
uptake in the right lung base and mild uptake in the left lobe.
Okay.
So in November of 23, I started on Orgovyx and Erlita. And within 3 months, my PSA dropped to 0.054. My testosterone dropped to 6. And it stayed that way for the full year that I was on the combination therapy. I finished the combination therapy in a year. And so in October of 2024, they stopped the Erlita and Orgovyx. And my subsequent PSAs stayed undetectable through, through April of 25, then January of 25, October of 24, July of 24. So it's basically been undetectable with very, very low testosterones. In January of this year, my testosterone went from 4 to 173 with my
Wow.
PSA 0.017. In April, my testosterone went to 194 with a PSA of less than zero point 0.1.
Were those bumps in your testosterone after your Orgovix and Erlita were stopped?
Correct.
Thank you. Okay.
Yep. And then my latest testing in July of this year, my PSA is 0.1, and my testosterone actually dropped to 164.
Okay.
And this
And
is
how,
after 12 months of Erlita and Orgovix.
yeah, I was a little concerned when they stopped it after 12 months, but it sounds like you're sustaining very low levels.
Yeah, my medical oncologist and my urologist were both very happy with the immediate response that I had to the combination therapy. And the plan is to go on intermittent therapy, um, probably when my PSA goes to 1.0.
So despite having small cell pathology, your prostate cancer appears to be responding nicely to hormone therapy,
It does.
right?
Yep.
That's very nice to hear.
Me, yeah, I'm happy with that.
Right at the present time, then, you're on no treatment at all.
None, zero, feel great.
Feel good?
Oh, God. It's amazing. It's amazing what a difference hormone therapy is before and after.
Yeah. Yep. There's a lot of sympathy for that in this room. Have you ever had any genetic testing,
Oh, sure. Negative across the board.
including tumor testing, not just bloodline?
Yep, everything. Everything that Rolando and Bulos offered me, I took. I've been in healthcare my entire life.
Yeah.
My current company is a company called Behavior, and what we try to do is improve patient compliance with their healthcare providers' directives. So I teach compliance, so I'm a pretty compliant person.
What brought you to AnCan besides
Russ Seneca, who I've
besides
been,
Russell?
well, that's it. You know, I've been following Russ, who has been um, on hormone intermittent treatment for, let's see, he started, I believe, 2009, if I'm not mistaken. So, you know, he's been on it for about 15 years. Russ and I are good friends.
I
And
was
we,
wondering if you would mind sending me an email of your one or two of your most recent biopsies. I would love to see them.
are you talking of the prostate or of the lung? Excuse me, I have never had a biopsy of the lung. I've had my removal of my right middle lobe because when they attempted the biopsy, the nodule that they saw there a number of years ago, they were unsuccessful. And in fact, when they removed my right middle lobe because they didn't want to mess around trying to take a biopsy and all of that, immediately post-op, they called it negative. And it wasn't until we had the full biopsy a full pathological evaluation that they discovered that it was metastatic prostate cancer. And going back to 22, my understanding from my physicians has been that the incidence of metastatic prostate cancer to the lung is pretty darn rare. And I
Yeah.
hear lately from my urologist that it's occurring more and more for some inexplicable reason.
No, it's really not that rare, especially early on. We've probably got 2 or 3 guys in this group right now who have experienced lung mets. We often see it early in the disease process, like in your case, and a lot of times they are able to biopsy it, but the concern is collapsing a lung in doing that. But what I've not heard of before is I don't think we've ever known anybody who's had a part of their lung removed. It's generally been treated. The other thing that's sort of strange is this small cell diagnosis. So the small cell diagnosis that Dr. Vivek found He confirmed that as being small cell prostate cancer or as neuroendocrine cancer of unknown origin.
Here is what I've got from 2021. Okay.
Mm-hmm.
So the removal of the right lung, the middle lobe, and lymph nodes showed metastatic cancer of one lymph node, metastatic prostate adenocarcinoma of the nodule, and
Mm-hmm.
neuroendocrine hyperplasia of the nodule.
Okay, so the neuroendocrine hyperplasia may not necessarily have been prostate.
Okay.
I'm sort of asking that, and maybe I should ask the Dr. Alfredo and Dr. John. How would you? Do we have any other docs in here today? How would you interpret that, gents?
Well, that's why I kind of wanted to see the written reports. You've got a number of us guys scratching our heads, and I thought maybe the precise wording would help me to understand a little better.
Yeah, I'm with,
Anybody else have any comments?
yeah, John, this is
Alfredo?
Alfredo. You took the words out of my mouth. I was going to ask for a lot more detail on those biopsies too, thinking that if I could read it, I would wrap my head around it. But
Yeah.
and
You see,
I'm thrilled to hear Rick say it's more common than we think, because I did
yeah,
not
it is.
said very rare.
Yeah, it's not as rare as you'd think. We've known a lot of guys who have got lung nodule. Like I say, I think there's probably I think there's at least 3 guys in this room right now who have experienced, and there may be more. The other thing that's really strange, Sam, is that if there was a concern, I mean, Vivek's a great doc. He really is, and we've done some work with him. We've actually done some research work with him. I have a lot of respect for him. Your treatment pattern is totally along the lines of adenocarcinoma. So he must have been fairly comfortable that there was no extensive small cell neuroendocrine like disease or risk thereof. Otherwise, I think the treatment pattern would have been different.
Okay. I'm sure I can pull up the original pathology report and forward it to whomever is interested.
If you forward it to John, I'm sure he'll share it, rather than flood you with email addresses.
I'm not sure which John it is in his email address.
Oh, Smiling John.
Okay, I'll put it in. I'll put it in the chat window for you. You know where the chat window is, Sam?
No, I don't. Maybe you
Okay.
could email it to me?
So no, just go to the top of the screen next to the 45, and there are 2 squares. Click on those squares, and there's a lot of action going on in that chat window.
Yes.
And I am just going to put in the Dr. John's email address.
Okay.
And
Already did it, Rick.
I see it. Dr. John at AnCan.org.
there you go.
I got it.
There you go. There you go. And we're going to ask you a big favor, Sam, as soon as you're done. If you could log out and log back in again, we would appreciate it. Somehow or other, you came in as an organizer, and we cannot demote you. So we need you to come. We'd prefer if you came in not as an organizer. Question for you: are you signed up? Do we have your email address?
I believe so. I believe so.
Yeah, Rick, he's all signed up. Rick. He's
Great. Dr. John, I'm concerned about your time. Maybe we just check quickly if there are any other questions and then move on.
You did, John.
Anybody else? Anybody else have any?
I just have one. I
Yes,
do have
please
one.
do.
If there are other people on the call who have had metastatic prostate cancer to the lung and who have been responsive to hormone deprivation, I wondered, besides Russ, how long they have been successfully treated with hormone suppression.
Richard has his hand up.
I have had metastasis to the lung since I was diagnosed late 2021. That is stable. The only thing that is not stable right now is lymph nodes. They have begun to grow and spread to several of the lymph nodes. That
And
answers
Richard,
the question.
what about the question about responsivity of the lung metastases to hormone therapy? He was wondering about.
Well, I've been on hormone therapy since early 22, and they have been stable all the time. I've got a lot of nodes that are all sub-centimeter in size. So that's the least of my problems right now.
Good luck.
Okay, very good.
Thank
All right, I'm going to move on to another one of our new people. The next card I have up here is Jerry and Cynthia. Let me see if I could find your pictures on here. Oh, there you are. Jerry with a G. Hello, welcome. How'd you find us?
Through Jim Marshall.
Oh. How old are you, Jerry?
70.
Where do you live?
Just outside of Rochester, New York, almost to Buffalo, upstate New York.
Okay. Tell us about go back to where you first got diagnosed and tell us how that happened and when it was.
I'm gonna just kind of speak out because I wrote all this down for him. So this happened. He was diagnosed in 2021 by a routine digital exam from his primary care. They found that there was a nodule. He went in for he was referred to a urologist who did a radical prostatectomy. His name was Abraham Glazer with Rochester Regional Health.
So that's the beginning of the story.
Okay. And probably before that prostatectomy, you had a biopsy. What did that show?
We don't have any of that information. We do have the information from the biopsy done during the prostatectomy.
Yeah, tell us about the pathology from the prostatectomy.
So he was given a score of 9, 4 plus 5.
Yeah.
He had mixed ductal acinar adenocarcinoma.
Okay.
Grade group was 5. Extraprostatic extension present, multifocal. Perineural invasion present.
Okay.
Margins were negative for adenocarcinoma.
Okay.
He had 6 lymph nodes biopsied, and carcinoma was found in 0.
Good.
So the histological type was mixed ductal and acinar adenocarcinoma.
Okay.
Urinary bladder neck invasion was not identified, nor was there seminal vesicle invasion identified, but the perineural invasion was present.
Okay. So then
Yeah, his
after this,
margins,
you said about the margins were clean. So
yes,
after this, you were followed by PSA tests,
yes.
and how did they go?
They've been steadily creeping up from less than 1 to, I believe, or less than 0.01. I'm now at
0.24.
0.24.
Okay. So you got 4 years out of that prostatectomy before your PSA started coming back
Yes,
with no treatment, no hormone therapy or anything.
correct.
Okay, fantastic. So that's really the nice part. The not so nice part is that you probably were thinking you were cured and now you're having some sort of recurrence. So since the PSA has gone back up to 0.24, have you had any further diagnostic tests?
I had a
PSMA,
PSMA.
beginning of July, I think that was, and that was negative.
No cancer found anywhere.
Correct.
It must have been too small to see, huh?
Well, that's what they're saying.
Anything else? Any MRI, any blood tests, gene tests?
No, he
Any
had
other
blood
kind of
work, but that was just for his
Primary.
primary care. There was nothing else, no gene tests, any of that. He was referred to an oncologist who recommended salvage radiation, and to begin that, the Lupron depot injection.
Who's that radiation oncologist that you went to?
His name is Dr. Sabit, Sabit, in Rochester Regional Health.
Okay. And that's the radiation person, right?
Correct.
Okay. So you didn't see a medical oncologist, but you saw a radiation oncologist, and he is suggesting or has already done radiation plus anti-hormone treatment.
He is suggesting that, and
We have not moved forward.
I'm scared of doing it.
Okay. So you're coming to us with a major treatment decision in front of you right now, aren't you?
Yes.
Okay. Are you leaning in one particular direction or anything?
It flip-flops daily.
Yeah.
Okay.
The reason that I think the radiation is frightening to him is because his mom had bowel cancer back in the day. It's a long time ago. Treatments were different, but she was pretty much burned out, literally, and had many issues for the rest of her life. I mean, she did have a long recovery, but she lived 45 more years, but it was not a happy one. So
Okay.
you know that there's things out there now. There's that Prostox. We can't get that in New York. We were interested in that, and then we were also interested in knowing if the let me see the name of that stuff. The spacer or the Barrigel could be used in someone without a prostate.
Okay. Okay. Well, you've come at a good time. You haven't had a second opinion yet, it sounds like, right?
No, we were hoping that we might be referred. He's got a primary care meeting on Tuesday. So we were hoping that maybe we can get a medical oncologist on board to hear the other side of the hormone treatment.
Yeah. Yeah, it sounds like a good idea because you have to decide whether you can get away with hormone therapy alone, radiation therapy alone, or whether you need the combination. And
Yes.
with the PET scan showing nothing, the radiation oncologist doesn't really have anything particular to aim at, so we'll probably just talk to you about radiation in the pelvis, which is presumably where these little growths are, right? Not for sure. Um, okay, and any other important medical issues?
Um, Let me see here.
No, for my primary care physician says for somebody my age, I'm in pretty good health.
Okay,
The only thing that I see is when he had his recent blood work, he's on the lower scale for lymphocytes. And, from what I understand, radiation therapy could lower that even more. So I'm concerned about that. Um,
what's
he's
the
got,
absolute lymphocyte number?
oh, geez. I don't know if I have that here. I think it was like 17 and 14 is
Okay,
the bottom.
okay.
He's also shy of vitamin D and B12, so we're working on that. And let me think, what else is there on here that I was thinking about? I was interested also in uh, with the Lupron indications about blood sugar and diabetes because he's on the upper scale of that, and his father, and it's really strong in his family. Many people have it, so I was concerned about that.
Any cancer in the family history?
Yes, his dad had lung, his mother had bowel, and his niece, who is 36, is stage 4, and I think she had lung cancer, non-smoker.
Okay. Well, we have probably 45 opinions for you among this group. There are people that have experienced a great deal of what you're talking about. Let's start with the idea about let's talk to Tony Fig about the idea of treatment options in your area, and if you do decide to have a second opinion, who you might go to. Okay, Tony.
Sure.
Yes, I've been using both Rochester Regional Health and University of Rochester Medical, and I had a radical prostatectomy, and within 2 months, I did start to experience a recurrence, and I found out about AnCan and looked into a GU medical oncologist and have one now at Wilmot Cancer Center, and his name is Brandon Garcio. And so I spoke with him and also with Dr. Kevin Byland, who's a radiation oncologist. And I decided to go with hormone therapy as well as SRT radiation. And with the radiation, I really didn't have any problems with any side effects, and it went pretty quickly. And I had a PSMA test, and there was no indication of any cells anywhere. So they did a pelvic girdle radiation treatment for salvage. But I've been very happy with the results that I've had with that. I was in remission for 2 years following the hormone treatment and radiation treatment.
So, so Tony, when you had to decide between hormone treatment, radiation treatment, or both, how did you make the decision to do both?
Really, the GU medical oncologist kind of led the way and felt that because it was an unknown, where the cancer is recurring, that it'd be better to cover both bases by doing it with hormone and that. So rather than try just the hormone therapy, I did both.
Gotcha. Ben, can you tell us what you're
Yeah.
thinking?
Oh, I
Ben,
wanted to
by the way,
interject,
Ben is one of our moderators, guys, one of our experts.
and also someone with mixed acinar and ductal, as is Tony. I wanted to point out that Tony is not just a rando on the call. He too has mixed ductal and ab- and acinar.
Anything else, Ben? Or is that what you were going to say?
And what would you say about hormone therapy to this couple?
It think it's I think it's a good idea given the risks of ductal. We've talked a lot about intraductal. People have been afraid of the risks. It's a different kind of variant. And I remember one doctor went in to see someone at MD Anderson, and he said, "Just be glad you don't have ductal." So ductal is a high risk variant, and I think it is wrong to worry about side effects when in fact you should be focusing on the risk of the cancer. I had like Tony, I had salvage radiation. My PSMA showed nothing. I had salvage radiation and ADT, which I kept up for a year. And yeah, I too have not had to date any serious side effects. I was fortunate, as was Tony, that the ADT did in fact control the my PSA.
And Ben, just for good order's sake, didn't you have something with your lung as well? I know you didn't speak up with I know you didn't speak up with Sam, but you did, didn't you have something involving your lung?
Yes, I was gonna. This call is bulging at the seams with to-dos. So I was going to send him a private message. Yes, I have lung oligomets and ADT. I was looking up the dates. ADT has been successful for me. I did it for a year with the salvage radiation. It was successful then, and I've been on it continuously since early 2021, and it has been working for me. So that's not a lost cause.
So, Jerry and Cynthia, we are lucky to have a couple of people here with a very, very similar pathology and treatment decision, both of whom have gone for the double therapy and both of whom have considerably benefited from it.
Okay, so if I may, I have a question. If the PET scan showed nothing, and you went and did the radiation, how do we know the radiation was effective and it wasn't just the hormone therapy? Where do I look for effectiveness?
Good question.
Did somebody else start talking?
Go ahead, and then I'll add to you.
The traditional way of following somebody after treatment is the PSA. Now, in addition, we have PSMA scans, and there's always symptoms. So you would be followed to see whether a recurrence happened by following your PSA, your PSMA maybe, your symptoms if they occurred. Now, if you did in the future have a recurrence, whether you could call that a failure of radiation or whether you could call it a failure of hormone therapy, it would be impossible to say. Of course, if you do two things, we don't know what does what.
So,
Go ahead,
Jerry,
Rick. Go ahead, Rick.
I would add is the following. The trials that we've seen over the last 15 years suggest that the optimal treatment is to combine radiation with hormone therapy. There's a question as to how much hormone therapy. The most recent trials seem to favor just 6 months, although the trials before that were a little bit longer. Um, but but the hormone therapy makes the radiation more effective. Now, I understand your concern about the radiation. Um, I think if it were me, I'd consider it to be essential if I wanted to stay on the right side of the grass. Because hopefully they will radiate, and this is where you might need to get more opinions. I know that that Tony really likes his radiation oncologist, so that's a good second opinion. But they probably should radiate across the pelvic girdle, all of the lymph nodes as well as the base. Sometimes they'll only just radiate the prostate bed, or they'll go up on two sides, what they call a rabbit's ear pattern. But our experience is, and if you read the literature, the most successful is to radiate widely. There's a lot of us in here who have had a lot of radiation. Radiation is not what it was in your mum's day, as Cynthia pointed out. And I really, especially with your diagnosis, to me, it's a no-brainer that you go in, you do what you got to do, you have your you do your radiation, whatever it is, 25 treatments, 30 treatments, and you do it with hormone therapy. I wouldn't do Lupron. I would do Orgovix, which is the pill, because it's going to allow your testosterone to come back way quicker. Lupron's really today an old drug, although many of us have done it, and all of those injectables are old drugs. If they are going to give you Lupron, make sure they give you the buffer first, which a lot of docs forget about. So you need to get bicalutamide, unless you get either Orgovix or a Firmagon shot. But we're sort of getting ahead of ourselves. But I think that the combination of Orgovix and radiation would be the gold standard for where you find yourself. That's what I would do if it came back for me.
So we did not hear about Orgovix or any buffer. And then the other thing was, to your point, it was to do a broad field with the bed and the lymph nodes in the pelvis. So yes, that was the correct.
So before you get your first hormone treatment, if you do go that way, come and talk to us.
Okay.
About the choice. We have a few opinions about that might help you out.
Yes.
I think that I would also like to see you get some genetic testing with that family history and make sure that there's not any gene mutations that are lurking in the background and might influence treatment decisions.
Yeah, especially with the combination of the lung and the prostate, there could be some things going on. So I absolutely agree with that, with Dr. John's suggestion. The other thing is, you really need to make sure, if they're not talking to you about, if they're just talking about sort of giving you a Lupron shot off the top, you've got to make sure you're going to a doctors who do a lot of prostate work, which Tony Figg assures me his doctor does do, because there was something on the website that made me question it, and he went back and checked. So we know Tony's radonc does a lot of prostate work, but make sure you've got somebody who really understands and knows prostate, because they're going to know about the importance of a buffer. And Tony, you have your hand up. Go ahead.
Yes, I was on hormone therapy for 6 months prior to getting the radiation, so they felt it was better to have the hormone therapy in my system for a while before they began the radiation. And as far as Lupron is concerned, you don't want to get into a 3-month injection. Better to start out with 1 month. But pertaining to Orgovex, that's a pill, and that would have to be covered under your prescription drug coverage. And if you get an injection, then that's done in the hospital or the doctor's office, and that's covered. Otherwise, Orgovex is very expensive, and your insurance may not cover an awful lot of it. So that's a consideration as well.
How often do you take that?
Daily.
How often do you take the
Daily.
Orgovex? Is it one dose or
Daily.
what? Oh, daily, okay.
Daily.
And they want to do a 6-month shot of Lupron.
Talk to us, please talk to us before you get your first shot. Because I'm a little pressed for time now because I got another new person, but I want to talk to you before your first shot, at least 5 days before your first shot. I want to go to my guys with hands up and then move on. Sam, let's start with you.
Yeah, just one quick comment. Both the companies that make Orlida and Orgovex have a patient assistance program. And if you're retired, not earning a lot of money, if you qualify financially, you can get the drug free.
Okay, thank you.
Okay. Yeah, and before you go to Dr. Alfredo, in no circumstances do you want a 6-month depot.
Okay.
If they are going to give you the Lupron, then probably go with 3-month depot. I mean, I would say 3-month depots are fine, but the problem with the 6-month depot, and again, it tells me your person is not that experienced, is that we sometimes see that it doesn't hold well at the back end. So it's just not it's not as reliable as the shorter ones, but we would steer you away from the Lupron anyway. Alfredo, go ahead.
I was just going to remark really quickly. I'm not trying to endorse anything. I just want to put out another point of view. When one is doing risk-benefit analysis and the risks are unknown and the benefits are unknown, it's difficult, right? So in my case of talking to 2 radiation oncologists, they both wanted to, they used the word spray the pelvis, and they were persuasive in getting me to think, great, we could either do a targeted radiation on the thing that lights up on my PSMA scan, which was very clear, size of a grape or raisin or whatever it was, or we can also put a little radiation in the neighborhood across the pelvis. And I was persuaded, and I have no regrets. I mean, it worked out okay so far, but I thought, yeah, in my case, it does make sense to put some radiation in some areas that are not lit up because we might be catching microscopic cancer. So I said, yeah, let's do it. It's just one viewpoint and something to think about.
Thank you very much.
Okay,
Welcome.
my last question is, how do we connect with you guys again, especially Tony, for more information locally?
Okay. So there's a couple of good ways to do that. First of all, I think I responded to you, and I think I copied Tony in there, so you probably have Tony's email, and I asked Tony to reach out to you, but you can use the chat window to exchange information right now. At the bottom where it says everyone, you can choose to send just to one person. And Mr. Fig has already put his email in there for you again. So there you go. And please, anybody in the group, feel free to reach out to anybody else in the group and ask them to exchange information. This is all about what happens outside the group as well as inside the group.
Also, Cynthia, I can
gel, protective gel injection if you have no prostate.
The gel is to protect your rectum, and some oncologists like to do it, and some don't think it's necessary. So start by having a discussion with your radiation oncologist about the pros and cons. I don't think it's commonly used in this situation because you can't really fit it between a prostate and a rectum in this now that the anatomy has changed. I'm going to move on because I got another person, but please come and see us again next week and write to me and Tony about any questions.
Thank you, everyone.
You're welcome. Jan, are you still here?
Yes, I am. And thank you for the time and the forum for allowing all of this. There's much to learn, and I'm definitely not up to speed as much as many of the men here, and possibly with Cynthia as involved as she is with her partner. So my name is Jan Falkowski. I'm 65 years old. I am from Grand Forks, British Columbia, which is 2 hours north of Spokane, immediately above the border. So definitely a Canadian. And my diagnosis, David Keller helped me write this out so that I keep it pretty precise. So my diagnosis is, as of about a week ago, is after biopsy, is a grade group 3 prostate cancer, adenocarcinoma. I've been referred to a radiation oncologist to set up radiation. This is by my urologist. The urologist's name is Dr. Robertson from Trail, British Columbia.
Let me just interrupt you for a second. Do you have high-risk prostate cancer? Because grade group 3 is 4+3.
That's what I have, yes.
Right, and that in and of itself is not high risk. So we just want to make sure you're in the right group. John, do you want to just take over and make sure? Because otherwise, Jan should be in the low intermediate.
When there are some people with 4+3 that belong in this group. For example, somebody who has been treated in the past and is now having a recurrence, or somebody that has a new metastasis, somebody who has some abnormal pathology in their biopsy, that's a very high risk. Does any of that sound like you?
Again, I've been referred here by David, so I'm...
maybe I could jump in for one quick second. Can you hear me okay, John? Dr. John?
Yeah, yep.
All right. I could have made an error, but he's got peripheral neural invasion. He's got cribriform. Yes, he's a 4+3 and a 3+4 with a high 4. He's been referred to radiation. He doesn't know anything about radiation, and I have no experience in that area. And I thought people in this group would know about radiation and can maybe help reverse that.
Yeah, we do, David. But this the cribriform is what generates the Gleason 4.
Okay.
Medically given. With that diagnosis, frankly, Jan should go to the next low intermediate group.
Okay.
Need to be in this group because we're going to be talking about things that are more aggressive treatment. So I would that next group. Bill Franklin, are you still with us?
I am still with you, yes.
Okay. When's Bill leads the low intermediate group. Bill, when's your next meeting?
2 weeks.
Ooh,
Can you guys hear me?
You're coming in.
It's a mess.
Hold on.
Yeah.
Excuse
me,
me,
guys. It is a week from Monday.
Yeah, it's
a week
the 25th.
from Monday.
Okay, it's a week from Monday. Jan, if you put your email address in the chat window, or David sends it to us or somewhere, we'll make sure you get an invitation. It's in this same room at on the 25th so we just had one yesterday, and we can give you all the information about radiation. We have a bunch of Canadians that we work with, but this isn't the best for you, and it's also not fair on the other 44 odd people who are here to take them through your case.
Yeah, Jan, we'll be happy to speak with you then. If you want to talk before then, if you don't want to wait 2 weeks, I'll put my email in the chat window. You feel free to text me, and to send me an email, and we can set up a time to talk also.
Yes, please do. Thank you very, very much. And thank you, Rick. Appreciate the guidance.
Jan, when you do follow up with those guys, get your hands on your actual pathology report. Some of us probably would like to see exactly how they describe that cribriform pathology. Okay.
Okay.
All right. Please stay if you're interested. Otherwise, Bill and Rick and I will see you in the low and intermediate group.
Perfect. I'll
Excellent.
stay if I could, please. And thank you.
Okay.
And my last statement is best of health, gentlemen.
Very nice to meet you.
We will add, Jan, right before you go, that Dr. John is currently a relatively close neighbor. How far away are you from Jan right now, Dr. John?
I don't know. I'm in Delta, BC, right next to Vancouver. Is that anywhere near you, or are you more in the interior?
I'm in the interior. I'm 6 hours drive from downtown Vancouver.
Okay, so he's way east, Rick, near my wife's relatives, actually. Okay.
Thank you, gentlemen. Well, let's go back to the meeting. We really appreciate your time, and we'll get a hold of this B. Franklin at AnCan as a contact I'm seeing on the chat. Thank you.
Let's start talking to some of our regulars. Steve L., you're the first guy. Tell us what's on your mind. I know you said we didn't have to get to you right away, but now that we have a little room to move, why don't you bring up what's on your mind?
Well, I'm trying to understand what I should call the radiation treatment that I have, that I recently completed, so I can do a little more research online. I was metastatic when I was diagnosed, so I never had any surgery or radiation to begin with. I had this radiation after I became castration resistant. And yeah, so it doesn't sound like it's salvage radiation to me. What should my radiation be called?
So let's see. So you had a prostatectomy, Steve?
No.
You never had a prostatectomy. You had hormone treatment.
Correct.
And then radiation after that?
Yeah, well, I had Provenge immediately after I became castration resistant, and then I had radiation 6 months after that.
Where?
Because your PSA went up or your scans became positive or something like that?
Yeah, and being oligometastatic, there was some research that indicated it could be very positive, and I wanted to pursue it and did.
So you're wondering if this gets termed as salvage or recurrent or whatever, right?
Mm-hmm.
Okay, Dennis, got your hand up?
Yes, how about debulking? Debulking, radiation to the prostate, right?
Yes. Well, it was to the prostate, the lymph nodes, and the pelvic bed. Yeah, it was pretty complete radiation, giving it an intensity that would be uh, typically be considered curative intent.
That might be different than what I had. Mine was main purpose, same thing. I didn't have prostatectomy or I did the chemo, and then a couple years later was the radiation. They thought to the primary tumor would help you extend overall survival. So that's what I had done, but I didn't have any, have it done to, well, I had another a site in the sacrum that they did also. And that was called debulking when I had my.
Yeah, yeah, I would endorse what Dennis said. The actual amount and the focus can change, but essentially what you had was a debulking process, Steve. And if you want to look at it and you want to find out more, I would use the term debulking radiation, prostate debulking. In the old days, when I say the old days, probably 15 years ago, we rarely saw anybody with metastatic disease having the primary treated. Mayo and I think Memorial Sloan Kettering were a couple of places where they did surgery from time to time, even with metastatic patients, especially Mayo did quite a bit. But we never saw radiation. And then probably 5 to 10 years ago, occasionally we started seeing people who were metastatic on diagnosis, getting radiation. And the last 5 years, it's been a lot more common because there have been studies that have come out that have shown that debulking the prostate, taking the primary out of the prostate with radiation, has very good results. And there's been a question as to whether that should be extended to the pelvis and across the pelvis. Some doctors say yes, some doctors say no. In your case, they did it, but I think it's all part of the debulking.
Okay, thank you.
Let's get some of our adjectives figured out here. I'm not too good at this myself. We've got primary radiation with curative intent right at the beginning. We've got neoadjuvant radiation. We've got adjuvant radiation. We've got salvage radiation. So what do you guys think about
neoadjuvant? Not neoadjuvant, Dr. John. We have neoadjuvant chemo, hormone therapy.
Okay.
We don't have neoadjuvant radiation.
So when I had my prostatectomy and then my PSA bounced back, that would have been called salvage radiation, right? Because I've been...
Well, not early salvage. So again, back in the day, adjuvant radiation was what they gave you if you had radiation within 6 weeks to 8 weeks after a radical prostatectomy. That was called adjuvant radiation, and adjuvant meaning it was added to the surgery. And then over the years, it became evident from studies that you maybe didn't need to get it right at the beginning within the first 6 months, 6 weeks to 3 months, that you could wait a little bit.
You could see how your PSA did.
And right. Well, the reason it was given up front without watching the PSA was because they may have found extraprostatic extension, positive margins, lymph nodes, different
No.
things. So they said, okay, we're going to jump right in after, as soon as you're healed up, and we're going to treat you.
Yep.
Well, a study, I can't remember the year of the study, maybe Len does, but a study came out that said it really doesn't make a lot of difference if we do this radiation 3 months after or 8 or 9 months after. And that's when we started calling that 8 or 9 months after early salvage radiation. So it wasn't exactly adjuvant, but then nobody was really doing adjuvant anyway because people were waiting. So the phraseology got changed. Salvage radiation was when it came much later, like in Jerry and Cynthia's case. That was typically salvage radiation when the PSA climbed, and maybe a year, 2 years later, we needed to jump in, and that's what we called salvage radiation. Debulking was a completely different issue altogether. Debulking was something that was innovated because the trial showed that even in the case of a metastatic man, where we were concerned about doing no additional harm because he was already metastatic, it was shown that treating that prostate could extend progression-free survival with the metastasis. And so men who had gotten chemo up front and who were on hormone therapy, it was determined that their progression would be retarded if they got radiation, and we called that debulking radiation. Any corrections, Professor Nathanson?
Yes, I've been quietly fuming. No, not at all. Right, right. I agree with what you said. Adjuvant, they just give it without even looking after the surgery. And between salvage and early salvage, salvage historically had been higher. The trigger point had been higher. It had been like 0.5. And right, the consensus is now doing it earlier, but actually looking for a rise first, not doing it without a rise. So I agree with everything you said, even though I just repeated it.
So Ben, in my case, I had, because of a rising PSA, 6 and 12 weeks after prostatectomy, I started on ADT and started radiation something like 6 or 7 months after my radical prostatectomy. So would you call that adjuvant or would you call that salvage?
You had it 6, 8 months just because, or were you looking at the
Oh,
PSA?
no, because my PSA was running away.
So it's salvage.
So it's salvage.
Early salvage.
I mean, whether it's right. I mean, now that they've invented the term early salvage, you know, what was your PSA at the time?
0.17.
It's early salvage, just as Rick said.
Yep. You know, there's another interesting discrepancy that I'm going to write about in one of my invitations someday. Rick and I one time discovered that we staged a new fellow with different staging numbers. And each of us thought we were right. Well, when we got together and tried to hammer it out, it turned out we were both right, because Rick was going for NCCN staging criteria, and I was using American Cancer Society staging criteria. I did not know that there was a conflict in staging criteria. So sometimes we got to go back and get our basic terms straightened out so we know what we're talking about. So let's see. So I think we've taken care of Steve, right? And had a useful discussion. Let's go to Cliff.
Hi.
Hi.
As you know, I've been on a drug holiday for about 2 years now, and my PSA is climbing. It went from, in 3 months, it went from 0.016 to 0.032. Now, I had my get my blood test, and that's what it came back. And I was supposed to meet with my doctor, but she had a family emergency, and I won't be seeing her until the 28th of the month. I was supposed to see her last week. Should I be concerned?
Well, here's what my particular doctor would do right now. Nothing. He would keep on getting quarterly PSAs, and I would probably be anxious and go in a little early until I hit zero point 0.2. Now, some people nowadays would pull the trigger at 0.15. Some people would even get a PSMA scan at 0.15, but I don't think anybody would do anything at 0.03 or whatever it is you said. But let's see if there's some other conflicting opinions among the
Let
guys.
me add one more thing. I don't produce a lot of PSA. As a matter of fact, when I was diagnosed with prostate cancer, I never even had. It was not even one. As a matter of
Wow.
fact, they were so surprised when I was diagnosed. They had the pathologist do the biopsy over again because it
In
was
that
just.
case, PSA may not be a meaningful method to track recurrence for you.
Right.
And so up comes an even more controversial question about should you get a PSMA scan even with such a miniature PSA level, given that you never make any. So let's get some opinions here. Jim Marshall?
Got a question for you, Cliff. Are you getting the testosterone test every time?
Oh yeah, yeah.
And how is it doing? Is it recovered a bunch? So
Yeah,
it might be a
500,
surprise?
500 plus.
Oh, so you are cooking it out. Yeah.
Yeah.
Well, with me, I've gone from 0.01 to 0.09 in 17 months. And the trigger point for me with Channing Paler is 1. But I may do it earlier if it starts to increase rapidly. So interesting.
Yeah. Yeah. I'm just trying to prepare myself mentally if I have to go back on ADT. And the radiation oncologist says, "Oh, don't worry, we're gonna zap it. If we see something, we're just gonna zap it." That's what he says. I don't know.
Mark, what's on your mind about this?
Well, Cliff, welcome to the non-PSA prostate cancer. It causes a lot of problems because it doesn't follow the rules.
It does.
My PSA was 1. I had a Gleason 9.
Same here.
And because of that, I didn't get treatment right away because they said, "Oh, you don't have prostate cancer." But what I've learned, the PSMA scans help discover cancer early. But I kept fighting both the insurance company and the doctors. They said, "We can't do this until it gets up higher." And I kept pushing them, and I could never get it as early as I wanted, but it was earlier than their normal line was. And every time it showed a bunch of cancer. And so I think getting the scan early, I think I missed some treatment options because we waited too long to get the scans. And then we're waiting until it got up to 0.2 or whatever.
I've
0.
had a PSMA, and but it was much earlier, and it was didn't show anything. By that time, they had knocked the cancer down really well with the ADT, because I'd been on it for 2 years, and that's when they decided to do a PSMA. And then I went into drug holiday, and I stayed at 0.014 for a long time, for about 2 years. Then it went up to 0.016, and then in 3 months it doubled, 1.6 to 3.2. So,
I can't tell.
Len,
have, doesn't produce a lot of PSA. That's pretty significant for me.
yeah, I'm glad you spoke up, Mark. That's really relevant. How about you, Len? You've been around this block.
Well, I'm not someone who doesn't produce PSA like Cliff. So I would agree with you, Dr. John, that PSA is not a meaningful measure of your status because you don't produce it. So on that basis, you should be able to make an argument with your oncologist to have the PSMA scan. And in the event that shows nothing, you could do a CT scan with contrast, or you could do a metabolic scan like Axumin, even though it's not supposedly state of the art anymore. It is a metabolic scan, whereas PSMA is not really a metabolic scan. It's only going to detect cancer on cells that are producing PSMA. But Axumin has a radioactive synthetic amino acid called flucyclovine, and that is picked up by any metabolizing cell and preferentially by cancer cells. So, yeah, I mean, first make the argument that you don't produce PSA, so argue for the PSMA scan. I think that's what I would do, and start there anyway. I guess we shouldn't get ahead of ourselves. Just start with that.
Okay, thank you.
Yeah,
that's the way I felt about it. PSMA should define anything that's out there. So, yeah.
Rick.
Yeah, I agree with everything that's been said. I just want to say you have a very solid GU medical oncologist, Dr. Pala.
Yeah.
Your situation is not the same as Jim's because you don't make PSA. I think that when you do see her, I don't think you have any. Well, if it were me, I wouldn't have a lot of concern about waiting until the end of the month at these low levels at all. But I would point out to her and remind her that you don't make PSA because sometimes that's overlooked when you recur. They forget to look at what you were diagnosed at.
Okay.
So, I would just make sure she understands that. I think she's solid enough. I know she understands these sort of these aggressive variant prostate cancers like yours and Mark Valens because she spoke about them at GU ASCO.
Mm-hmm.
So I think you're in good shape, but just stress the fact you don't make, and how can we be looking for this early?
Right. Thank you.
There was a paper a few years ago by Petrolak and I think Armstrong looking at some data from an older study about recurrences, and there were a significant number of people who recurred radiologically but did not recur biochemically. We know it's possible. Larry Fish?
Yeah, hi. Can you hear me?
Barely, Larry.
Oh, is that better?
That is better.
Okay. This makes me think about the way that I think about cancer cells. I don't think that you necessarily have, one kind of cancer cell exclusively. So you kind of cancer that not what's his name? The man who was talking, who we know, talks about this cancer that doesn't produce a lot of PSA. And now he sees a little rise in PSA. So it makes me think that he has, some small percentage of cells that do produce PSA, and the majority of cells historically have not produced PSA. So you can have both at the same time, and I think the increase in the PSA producing cells is a concern enough to keep your eye on it. But it seems like so far that level is too low to show up as a metastasis. So I think you have to look at I don't know if this is all legal philosophy, but I think you have to look at it from both directions, from the non-producing PSA cells and from cells that may also be producing PSA, and keep two trains of thought going, in addition to the overall of getting a scan that might show a metastasis.
Well, I think you're right in that. I as the patient, I'm always going to err on the side of caution when I see anything rising in a PSA, even though I know I don't produce a lot of PSMA.
Well,
I'm just going to be cautious anytime I see any numbers rising now.
yeah, I feel, Cliff, that that's basically has been historically the case, but now there might be some morphing, or there may have been some small percentage of cells that may have produced, maybe PSA producing, but just haven't been significant enough numbers to show anything.
Right.
So it seems like the question is whether this is just a change or like a second track. So I think you should follow both. That's my opinion. I don't know. I'll talk to my doctor about this theory. That
I think Larry brings up a good point that we should always remind us of, which is that it's not like a cancer cell develops and starts dividing and then has millions of clones that are all exactly alike. It's not like that with prostate cancer. Prostate cancer, especially as it advances, is notoriously heterogeneous. And just like Larry says, you could have some cells doing this and some cells doing that, and we shouldn't forget that there's different populations inside most of our cancers. Okay, I'm going to go on to RJ. What's going
Thank you.
on?
Thank you very much, y'all.
You're welcome, Cliff.
Hey there. So,
Hi, RJ.
You hear me?
Yes.
Okay, good. So, update on my treatment. I'm on week 6 of the hormone treatment and finished today my 4th session of the radiation, the IMRT. So I'm on the Lupron and abiraterone, and that seems to be going okay. The side effects are tolerable but not debilitating, is the way that I think about it. And it's okay compared to the alternative. And then also it has brought down my PSA. So I had a PSA test last week. So in 4 weeks it came down from, I think it was 13 down to 0.37. So it's working. And the radiation, so what my plan is, I have 2 different radiation oncologists. They're both at Swedish in Seattle. One is going to do the SBRT after I do the IMRT, so I'm doing the 5 weeks, and then a follow-up of boost, and then also a separate SBRT for my ribs. Probably just one of the ribs, where when I got the PSMA PET scan, it was oligometastatic. So, but most of it was kind of like spots or shadows. There was one in my rib that was very pronounced, and they said, yeah, that's pretty much a lesion there. So they're going to treat that with the SBRT. And then I also had left and right iliac in my pelvis, as well as sacrum and pubic bone. And what the guy that's doing the IMRT, they're doing a very wide field, and he said that will take care of those metastases. That with the radiation treatment that they're doing in my pelvic bed or girdle. I'm not sure exactly what the right term for that is, but that will take care of all of those metastases. But then they have to go get and do the ribs separately. So, and then they're going to come back in 3 sessions of SBRT for both prostate as well as I had metastases in my iliac lymph node. I think there's 2 of them where they saw that on the PSMA PET scan.
So the lesson here, I think, is how to avoid docetaxel, isn't it?
Well, that was my question, actually. And so what my medical oncologist, so I'm on the dual hormone treatment. So, and then what he said was, well, if you want to do triple therapy, it is a standard of care. And you can do that, or you can do it as part of a trial. And he said, if you want to do chemotherapy, you can. You don't have to. You can do it later. And so that was one of my questions, and to get some feedback from people either that have done a lot of research in this area or talked to a lot of people or have done it themselves is, should I get the chemotherapy after I finish the radiation, or should I wait and see if I have a recurrence?
Hey, great question. What thoughts do you guys have?
How many metastatic spots did you have originally, RJ?
It depends on how you count and whether or not you count them, but I would say right around 5.
See, that's why there's confusion, because you're sort of right on the cusp. You know, if you had 2 or 3, we'd say, oh, you're doing great. If you had, God forbid, 10 spots, we'd say, do the chemo. But the reason the guys and the docs are sort of sitting on the fence is because they don't want to overtreat you. At the same time, you're sort of right in the middle. So I think from your standpoint, if it were me, I'd probably see how it went, how I was doing, and if you continue to see Schweitzer, I know that that's one of the docs that you've been talking to, and yep, that's it.
Yeah, and one thing that Schweitzer said is I could do 4 of the treatments, and if the 4th one becomes a bit much, he said you can stop then.
Yeah,
like enough is enough. And then, but he said, if you get to 4 and you're kind of like, well, this is a breeze, then, and what I would prefer to do is to do as much as I can, as much as I can tolerate, so that I don't have to, essentially wait until later. And then,
yeah, well, then if you're willing to do that, I'd go for the chemo. I think you've answered your own question, Len, what would you do, Len?
Well, Rick, you started off saying, I think, wait until you have a recurrence. Personally, that's what I would do. I wouldn't take chemotherapy if I didn't have any recurrence. The other thing I wanted to ask you, RJ, is what were the SUV values of those bone lesions? Do you recall?
They didn't actually give me SUV values.
Oh, that's pretty important, because if they're less than 10, I wouldn't be too concerned about it. It could be that the hormone therapy will eventually resolve those. I mean, if you had something over 10, SUV over 10 or 20, something like that, that's definitely worth having SBRT treatment to those lesions.
Yeah, and that's what the radiation oncologist said. You know, they didn't give me an SUV for the rib metastasis, but he said that definitely that would show up on a bone scan, and so we would call that a lesion. That's definitely a metastasis, and that can be treated with SBRT, so that you don't have to worry about it growing. You know, even if the hormone treatment kept it kind of in check, that you can actually ablate it with the SBRT. Of course, he's a radiation oncologist, and I understand everybody has their own perspective, and I'm developing my perspective, which is, you know, the other thing is I'm actually taking time off work. I'm starting with a couple of months because all the just logistics around this has become a bit overwhelming. So I'm kind of like, well, if I'm going to take time off from work, maybe I just want to get as much taken care of now as I can.
Remember too how screwy the PSA response to radiation therapy is. You know, it jumps all over the place, and it might take a long time to manifest itself. I mean, you may even go lower than 0.37 if you just wait a little while. It sure is an interesting question and can be debated on both sides. And I don't know what I'd do. I think I'd wait. Any other opinions before I move on? I got several more people. Okay, great
All right.
question. Jerry.
Yeah, real quick. I just want to give you an update. I had a full CBC lipid blood work, but I also, Dr. E also included a Tempest, and the Tempest came back with good news, 0.06 percentage of cancer cells in my blood. And then we did a PSMA scan, and it came back clear. No indication at all of any cancer. So Dr. E still has me on Orivix and Nubeqa, and she wants to wait for another 3 months because I'm starting to ask her when I can stop. And so she said we discussed that in 3 months, and then she definitely wants to have another PSMA PET scan in 6 months. So that's my update, real quick.
That sounds good. Your cancer is currently fast asleep.
Yeah, she even said remission. So
comments from anybody? Questions?
Good.
Oh, thank you for that. Okay.
I have one quick comment, Dr. John, because
Yeah.
I'm sitting here thinking about Jerry and Debbie and when they first came to us, which was a long time ago. I think it was 7 years ago. And
2019.
What a state they were. So and Jerry was one of these guys with an enormous PSA, 3,100, I think it was, in 2019, and Debbie thought, oh, he's not going to make it for another year. Now she can't wait to get rid of him 6 years later.
Yeah, true. Actually, the last time I saw Dr. Singh at Mayo, which was probably 2.5 years ago, he actually intimated to me that he thought when he first saw me that I probably would be gone in 3 years.
Ah.
Yeah, you've done so well, Jerry. It gives us a lot of joy just to see you on the screen.
Well, thank you. I'm glad to be on the screen.
It's so nice too that your doctor held back on that prognosis until all this time went by. I can't stand it when they say that right at the beginning. Let's go to Luther and then George and John. Luther, can want to do some catching up?
Yeah, sure. I don't drop into this group that often, but I'm a year into doublet therapy after radical prostatectomy and salvage radiation. Radiation was done last December. Had my routine checkup yesterday, ended up being with a medical assistant. Wasn't expecting any treatment decisions, but she got concerned with some when I told her I'd had a few allergic reactions, my lip swelling and a couple of hives, which is really weird for me. So long story short, she thinks I should switch to darolutamide, which I walked out of there yesterday with a 15-day supply of that, so I'm ready to go. I
Wait,
guess
you're
my
still on abiraterone, right?
was on abiraterone and Eligard, and I've had no real issues with abiraterone except this
Wait, did you
little.
say was on? Was on
I
out?
I have been on abiraterone for a year along with Eligard up until my appointment yesterday,
Okay, that's what I wanted to clear up. Okay, thank you.
and so she told me to stop the abiraterone because she's concerned about the facial edema becoming an emergency event, and we have nothing else to attribute it to. So I guess my question is, let me back up 1 second. I have very successfully managed my hot flashes with oxybutynin on abiraterone. I think from these groups I've learned that that does not work with any of the eye drugs. She suggested I could try venlafaxine. It's an SNRI to control hot flashes. And I'm wondering if anyone has tried that. I will be having further discussions. I'll meet with my actual medical oncologist in about 4 weeks and my primary care because I'm already on a different SSRI, so I would have to taper on and off both drugs. Looks like we already have a couple hands up. So
Okay, let's see.
Can I just ask one question? When she took you off the Abbey, what did she tell you about prednisone?
Yeah.
I had to suggest a taper. She said they usually just have people stop.
No, they don't. So the reason I'm saying it is I don't put a lot of quality in these medical assistants. And I would not put quality in her recommendation to start Darrow if she just tells people to stop prednisone, because that is a really, really dangerous thing to do. And there's a lot of guys on this call that will say that, Luther. I would keep taking your Abby and wait until you see who's your doc? Amling, is it?
Dr. Ung.
Oh, Dr. Ung. So I would wait until you see him. I would revisit at that point in time. I don't trust what she told you.
Well, she's concerned enough about the Abbey that she gave me an EpiPen and basically told me to go to the ER if I have my lip swells up again.
Good Lord.
I mean, tell them you need to meet with a GU medical oncologist before you do anything further, because she cannot be telling you just to stop prednisone. And whoever, right. And when you speak to your doctors, you tell them this assistant told me to stop prednisone cold. That is so dangerous.
I got her to re-up my supply, so I've got about 40 pills of 5 milligram. I was going to initiate a slow taper.
Okay, but you shouldn't have to do that. Because we've drummed it into everybody here. But when you've got a medical practitioner who tells you, oh, well, she doesn't know what she's talking about. Okay. I guarantee that one of the doctors there wouldn't say that. And frankly, if you've got issues with edema in your lips, I can't say it isn't a side effect of Abby, but I've certainly never heard edema in your lips as being a side effect of abiraterone. I don't know if anybody else has. So my thinking is it's probably totally unrelated. You're happy on your abiraterone, you're managing it well, and I don't know where she's getting that from. So that would be how I would respond, and I'd wait to see a doc, and these damn medical assistants should not be making treatment decisions.
You can even write to your doctor on the patient portal today and say, I just want to make sure you guys are talking to each other. And what is 5 the dose you've been on all along? 5 of Abby?
It's been 5.
Prednisone, you mean, Dr.
I mean
John?
prednisone. Thank you. Yeah. It's been 5. I had to stop
once a day or twice a day.
Because
once a day or twice a day.
Once a day, Rick.
Okay. That's at least good.
Well, I mean, my thought was, well, I think Darrow's a better drug. It's an excuse to get over to that, but
Look, Cliff, you have a comment about this.
Yeah, I'd like to speak about venlafaxine. So before I switched over to Channing Paula, I was at Walter Reed, and they put me on venlafaxine for hot flashes. First, it didn't work. Second, it's extremely hard to get off of. I wound up, when I was trying to taper off of it, I wound up in the emergency room a couple of times. I was down to one half of a pill, and I still couldn't get off of it, and without some type of side effect. So please be cautious when taking venlafaxine. It's terrible. It's a terrible drug, as far as I'm concerned.
And I'll second that. I was on 250 milligrams of venlafaxine going through my treatment, and I'm down to 75. I wanted to get off it, and I second Cliff exactly. I tried to get off it, and I couldn't. And I am back on 75, and I started reading about everything and looking into it, and it's absolutely ridiculous to start venlafaxine. Believe me, any SSRI, unless you absolutely have to. And when you do, man, keep in mind you're going to be on it for the rest of your life. I don't know, Rick, if you've tried to stop, Rick, but boy, I can't.
Okay, Jerry, thank you. I want to get back to the more urgent side of the question. Rick, do you want to follow up about the prednisone?
Well, a couple of things. First of all, with respect to venlafaxine, it didn't do anything for me in helping, but that might have been because I was already on it. So it didn't help me. It did not help with my hot flashes. I'd also just point out to Jerry, it's an SNRI, not an SSRI.
I knew that, Rick. Yeah.
You said SSRI. I don't want to get into getting on it and getting off it. I adjust my dose all the time. I do fine on it, but everybody's different. I think that the prednisone issue is a huge one. I think that if I were you right now, I would be making an appointment to talk to somebody else about what's causing the edema in your lips. You've had no heart issues, correct? Have you any AFib or anything like that?
I had a coronary artery calcium test 6 months ago. The result came back as 0, no other heart issues.
Your blood pressure's okay?
Blood pressure is around 125 over high 70s most of the time. It varies a little bit.
Okay. Thank you. Go ahead, Rick. I just wanted to not forget.
I was just going to say to you, Dr. John, I mean, do you think that this lip edema is is relate. I mean, obviously we can't give a medical opinion, not your patient, but lipedema and abiraterone. What do you have to say on that one?
Well, edema and abiraterone, absolutely, especially lower extremities associated with blood pressure problems. Lipedema seems more local. I mean, I'm no allergist, but it seems like a somewhat local phenomena. Of course, the abiraterone is taken in the mouth. I wouldn't say that it was impossible, but we've never heard of it.
Is it reported anywhere? Do any of our guys know? Have they seen lipedema reported with abiraterone?
I'll look it up while you keep the guys talking.
Okay. We're checking it out, but I really would say if it were me and I wasn't getting the hot flashes, the oxybutynin was doing good by me. I wasn't having a problem with the abiraterone, and the only thing that's an issue is this lipedema right now. I'd stick with that and then wait to speak to your doc. David Opp, you have your hand up.
Yes, I've been on. This is the second time I'm on venlafaxine, and it provides 95 to 100% hot flash control for me. I did stop it, must be about 3 years ago, and really had no issues with weaning off of it at all. So it's just an individual thing. Some people it works, some it doesn't.
Yeah, exactly. For some it does, for some it doesn't. You've heard 2 against and 1 for. Actually 3 against and 1 for, but I don't count myself because I think my system was already too used to it.
I found edema very actively and in high percentages, but particularly lipedema not mentioned anywhere.
Yeah.
Her concern is, it could spread and obstruct breathing.
Yeah.
Well, if it's an allergy, she's acting as if it's an acute allergy. So, talk to somebody else. We think it's wise that you are going to continue a very slow taper if you do stop the abiraterone on your own, even if you don't do it with her blessing. We think you need to talk to the MD on the case. Darolutamide is a perfectly great drug, but so is abiraterone, and you'd hate to lose it if you don't have to.
Right. Okay. I'll follow up. I'll ask to speak to the doctor on the phone. The complication is I'm headed out of town for 3 weeks, in a day. So we'll see.
Well, write to them and get this looked at right away, because an anaphylactic reaction is nothing to shake off and say, I'll deal with this later. If you really do have swelling, itching in your palms, difficulty breathing, rash, anything like that, then take it.
I have had palm itching. I had no idea what it was. That happens to me quite often. Like my hands are just itchy.
How about before you were ever on Abby? No. I take the possibility seriously, but talk to somebody, even if you have to get to an allergist or something.
Okay.
So the safest thing you can do is to ditch the Abby, take the darolutamide, and put yourself on a long taper of the prednisone. But the abiraterone may be salvageable. We can't tell.
Okay.
The other thing is that if they do think that the Abbey is responsible, then they're required to report it. And we're obliged to mention that to you. Because a couple of our sponsors have insisted that either you or your medical team report adverse events, Luther.
We're out of time now, but there's no group coming in, we can continue on for the last couple of guys, but anybody that has to go, do so. Are we good for a few
have
more
a,
minutes?
we have a group coming in, but we have another 15 minutes, John.
Okay, let's see what George has going on.
Thanks, Dr. John. I want to be very, very brief. I was diagnosed with intraductal in April this year. MRI biopsy, PSMA, germline. The PSMA and the germline were negative, but we do know how intraductal behaves. I went to see Egner. That had limitations because he's really not going to be seeing me. So he suggested that I see Sidana, and Can also suggested that I see Sidana. And I've made an appointment to see him at the end of September. I need to basically make decisions about treatment. I'm inclined to go with radiation. I called Dr. Liao, but had a hard time getting an appointment. The bureaucracy took over. They wanted some sort of a reference, etc. So I'm going to try to call again and make an appointment with him independently. But that's where I am. I'm going to see Sidana at the end of September, and hopefully I can get an appointment with Liao.
Okay.
It's there are no extensions. Presumably there are no extensions. It's localized, but again, we know how intraductal behaves, and it must be treated. So I'm in that path. And it's a lot to digest in a very short period of time. So I'm trying to do the best I can.
Ben.
Which, I hope you talked about some other things. For instance, a live question on these calls, and certainly for me, is whether radiation is an effective treatment for intraductal. Did Egner have any thoughts on that?
He didn't. He actually recommended radiation, and he did not shy away from focal, which surprised me, frankly. Now, I do not, I did the germline, and I do not have BRCA1 and 2 mutations. My understanding is that if you do, radiation does not work properly. I don't know how true that is, but he did recommend radiation, yes, with ADT.
Okay.
So that's where I am.
What exactly did he say about focal?
Well, he said that it's experimental, that we don't know what the net result would be, but he did not eliminate it entirely. That's what I got from it, frankly. But I'm not inclined to go that way, frankly.
Okay, thanks.
Thank
The
you.
world's gone crazy. I can't imagine entertaining the thought of focal
No.
for something as high risk and likely to, have proliferated.
Yes. 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 Yeah. So that's what I have, frankly.
How's our comfort level with wait until the end of September before doing anything?
It is not good, and I'm sort of calling every couple days to see if I can get an earlier appointment. I'm on a waiting list, but you know how that is. I wonder whether I could see the radiation oncologist before I see Sidana to sort of get a sense of where he would go. I mean, all my tests are at the University of Chicago. All the paperwork is in there, so he would have access to it. So in answer to your question, I'd rather see him sooner, frankly, and I'm going to try to do so.
And I don't see any harm in getting to a radiation oncologist to discuss Ben's question.
I don't either. So, but the bureaucracy takes over again, and it's kind of, they tell you, well, we need a referral from Sidana. Now, I've only been told that once, so I will persist and I will call tomorrow again. maybe I'll speak with somebody else.
Rick, any comments about this
Yeah, I
navigation?
do. I would send an email to Egner in the portal and ask Egner to refer you to Liao as soon as possible, and also ask him, can he try and get you an earlier appointment with Sidana? That you're concerned and you don't want to wait. So I would lean on Egner to do that. Somebody's going to be reading it, even if he's in transit, and try and get an earlier appointment with Sedana and try and get a referral to Liao through Egner.
I'll do that as soon as we hang up. Thank you.
The last guy on my list is John, but I don't see him. Are you still here, John?
Which
there
John?
he is. John M.
Oh, okay.
Hey, I waited right till the end, right? So, first of all, George, I did speak with Egner. I think he's a super guy. I did not use him, but he seemed very helpful to me. Stanley Liao is the guy. He's great. Reach out to me separately. I may have some suggestions in Chicago. Okay.
Thank you.
Second, quick one. I was diagnosed end of December, 3-course Gleason 8. I'd done Orgovyx and abiraterone. I had brachytherapy, and I did 25 sessions of radiation. I've got 2 consecutive months where my PSA was undetectable and my testosterone undetectable. I got hot flashes, but I got the wristband. It's either a placebo or it's working a little bit, right? A little bit. And I just want you to know that it means a lot for me to be here on the call with all of you. I'm inspired. I'm learning a lot, and I got a long road ahead, and I'm going to be here when I can. So I just want to say thank you to all of you. Right?
Well, thank you. So you have a recent PSA still non-detectable.
I have 2 consecutive months of undetectable PSA and undetectable testosterone.
Fantastic.
So we're on the path.
I see your PSA was 4.9 a couple of months ago. Yep.
Oh yeah. I was way high. So
okay, last word, anybody, before we turn the room over to the next group? We sure talked about some interesting stuff here today, didn't we?
Sure
and I'll see everybody next Monday.
Thank you, John.
I just want before we turn that recording off, I just want to give a vote of thanks to Dr. John. He had probably, I'm guessing, 47 or 48 people in the room max. He had 2.5 new people. Thank God we one of them really should have been, and he still finished only 10 minutes late. So I think that deserves a real round of applause, or some love hearts, some hearts you can put some hearts there, and I'm going to put a heart in the chat window. Fantastic.
Okay, keep those hearts coming. See you later,
Thank you very much.
everybody. Bye now.
Good night.
Good night, everyone.
Good night, everyone.
I'm here.
Thank you.
Maxwell, hold on a second, and I'll talk to you about your question.
I'm not going anywhere.
All right. Good night. Good night, everybody else.
Good night, everybody.
Good night.
Bye.
Good night. Good night. Good night.